Percutaneous dilatational tracheostomy is a simple, cost-effective alternative to standard open tracheostomy. This approach also results in less trauma to the patient and is routinely performed bedside. The Cook-Chaya Blue Rhino percutaneous tracheostomy introducer set has been designed for controlled elective insertion of a tracheostomy tube. The improved design of the Blue Rhino has a remarkably flexible tip for a less traumatic approach. Its soft, pliant, curved contour is passed over a guiding catheter to create a proper tracheostomy opening in just one pass. The Blue Rhino's slippery hydrophilic coating and tapered profile eliminate the need for multiple passes with increasingly larger dilators, making the procedure quicker and possibly decreasing the risk of tracheal wall trauma. And the Blue Rhino is also cost-effective because it can be used in a bedside procedure, avoiding OR expenses. Indications for a percutaneous dilatational tracheostomy are identical to those for conventional surgical tracheostomy. Absolute contraindications include emergency tracheostomy, pediatric applications, the presence of a midline neck mass, and non-intubated patients. Relative contraindications include a PEEP value greater than or equal to 20, or uncorrected coagulopathy. Sedation includes a combination of intravenous analgesics, anxiolytics, and short-acting paralytics. The patient should be placed on 100% oxygen with volume adjusted to compensate for the presence of the bronchoscope. For this patient, a fenestrated tapered tracheostomy tube with the inner cannula removed is preloaded with an appropriately sized lubricated dilator. However, any standard tracheostomy tube may be used. The tracheostomy tube is positioned so that the tip is approximately 2 centimeters from the distal tip of the dilator. First, the patient is positioned as for a traditional tracheostomy with a transverse shoulder roll to permit full extension of the head and neck. The neck and upper chest are sterilely prepped and draped in the standard fashion. Critical anatomical landmarks, the thyroid cartilage, cricoid cartilage, and the sternal notch are identified by palpation and marked. The incision site is infiltrated with 1% lidocaine with epinephrine. A 1.5 to 2 centimeter transverse skin incision, just long enough to admit the tracheostomy tube, is made at the level of the first and second, or second and third tracheal rings, approximately 1 finger breadth above the sternal notch. A curved mosquito or hemostat may then be used to gently separate the subcutaneous tissues vertically and transversely. Digital palpation is then used to free any tissue while identifying the cricoid cartilage and the tracheal rings through the incision. A bronchoscope is then inserted through the endotracheal tube and aligned with the tube. The respiratory therapist then loosens the fixation tapes of the endotracheal tube, deflates the cuff, and withdraws the ETT and bronchoscope slowly as a unit until the light from the bronchoscope transilluminates through the incision. Necessary changes in tidal volume and frequency should be made to accommodate the bronchoscope and any air leak that may occur during dilatation. Access and ultimate tube placement is made at the level between the first and second, or second and third tracheal rings. Tracheal rings are palpated, and a 15-gauge introducer needle is inserted in a midline and intercartilaginous position under direct bronchoscopic visualization. Care is taken to avoid the posterior tracheal wall. The needle is removed, and the 52/1000-inch J-tipped wire is threaded through the outer catheter into the trachea to the level of the carina. The sheath is then removed and replaced by the 14 French introducer dilator, which is advanced over the wire guide to dilate the initial access site. Some compression of the anterior tracheal wall is expected.